Hey everyone, and welcome to Hospital Medicine Essentials. This is COPD Exacerbation, presented by the IM Chiefs. COPD has a subject authority called GOLD, which produces the guidelines. Most of what you'll see in this presentation is from their 2024 report. So let's go ahead and get started. Chronic obstructive pulmonary disease has many causes. Smoking is the big one, but some others include alpha-1 antitrypsin deficiency and indoor biomass fuel use. The main symptom you're going to see is dyspnea, but there's a lot of others that are listed here. Common patterns are emphysema, which is enlargement of the air spaces and destruction of the alveoli, and chronic bronchitis, which is a regular productive cough for at least 3 months in 2 consecutive years. In reality, it's a little bit more complex than that. But no matter what, a patient cannot have COPD unless they have spirometry that showed a post-bronchodilator FEV1 over FVC ratio of less than 0.7. That's the definition. A lot of people that are older, have a smoking history, show up with dyspnea, they're going to get tagged with a COPD exacerbation. But one great way to be helpful on your hospital medicine rounds is to actually dig through their chart and find out whether they have spirometry, which says that they for sure have COPD. So how do we classify COPD? There's the MMRC and the CAT, so those are symptom severity scores. Anybody that you see in the hospital is going to automatically be in Group E, meaning they've been hospitalized for a COPD exacerbation. This means that their appropriate outpatient therapy is going to be a LABA plus a LAMA, and then maybe an inhaled corticosteroid, which we'll get into later. So what is a COPD exacerbation? It's at least 2 of increased dyspnea, cough, or sputum purulence, which is color change, but also you might hear production mentioned as well. Symptoms will worsen over less than 2 weeks, and if a patient is hospitalized, that's automatically considered a severe exacerbation. Something that you're going to want to think about is if they're having something else going on at the same time as this exacerbation. Infection is overwhelmingly the most common, and this could be viral or bacterial. Pollution and heart failure can also cause it, and then the one you can't miss is pulmonary embolism. This can be sneaky, has very similar symptoms to a COPD exacerbation, so you're going to want to keep a sharp eye out for that. So now you've diagnosed COPD exacerbation, how are you going to treat it? So you're going to start with a short-acting beta agonist plus or minus a short-acting muscarinic antagonist. As soon as possible, you're going to want to add that long-term therapy, so the long-acting beta agonist and the long-acting muscarinic antagonist. You can do an inhaled corticosteroid if appropriate, so when the blood eosinophils are at least 300. Systemic corticosteroids for 5 or less days, and then most people will get ceftriaxone and or azithromycin. This is pretty controversial, especially if there's no sputum purulence or other signs of bacterial pneumonia. The antibiotics might not be necessary, but a lot of people put them on them anyway. And a really important thing is being able to identify signs of impending respiratory failure. These are the GOLD report signs and symptoms, but use your clinical judgment. If the respiratory rate is 30 or more, if they're working super hard to breathe, they're likely to tire out and they're going to need help. If they have mental status changes, that means they've gotten hypercapnic and they may need intubation and mechanical ventilation. If their blood gas looks horrible, that is objective respiratory failure. If you see this, call someone right away. These patients need help. As you consider respiratory support, remember, COPD is a failure of ventilation first and foremost rather than oxygenation. So your patients are going to do better with positive pressure like BiPAP or very high volume, high flow blender. So how can you help your patients at discharge? The last thing to think about is what can you do as they're getting ready to leave. The main thing is to talk to them about smoking cessation. Use motivational interviewing, ask them if they've ever tried medication-assisted quitting. They could use Chantix, nicotine patches, gum, those types of things. This is the best thing for them, has the most mortality benefit. Pulmonary rehab is also excellent. COPD causes a vicious cycle where exercise causes dyspnea, so patients move around less and they decondition, their exercise tolerance decreases. It's an endless cycle. But this rehab can help them break out of that cycle. And they have a mortality benefit, they have improved exercise tolerance, and just a better sense of how much dyspnea is safe versus when it's assigned to stop. So you can kind of help them get their life back. In the right patient, supplemental O2 and non-invasive positive pressure ventilation and lung volume reduction surgery can also confer mortality benefit, but that's a little bit beyond the scope of this talk. It's in the guidelines if you'd like to look it up. Well, that's all we have for you on COPD exacerbation. Feel free to email Mark or Michaela with any questions you might have. You can also check out the Gold Link report for 2024. They've got a very long guide, but there's also a pocket guide, which is shorter, mostly bullet points, figures, plus a slideshow version if you would prefer that as well. Hope this was helpful. Good luck with your studying.